stubbornness to patella and to fibular head, and inability to flex the knee joint up to 90 degree immediately after the injury. And the fourth thing is inability to do 4 steps work immediately after the injury and in the OPD setting, regardless of limping. This is whatever only. I already explained the management protocol of injury grade 1, grade 2, and also we explained about the injury management rise and non-harm. Coming to knee joint pathology. Regarding knee joint pathology, here we shall discuss about mainly osteoarthritis. Osteoarthritis is the most common condition affecting knee joint. Iliotibial band syndrome related with sports injury, and also it is not related to sports injury. It may happen above the age of 50 in rickshaw pullers or in persons who bear weight and walk through the slanting surfaces. Chondromalacia patella, which is very common in females, patellar tendinitis, and Osgood-Schlatters disease. Osteoarthritis, as we all know, there is no need of explanation for osteoarthritis. Mainly, I will focus on the clinical examination to diagnose. Regarding X-ray, there will be narrowing of joint space, sclerosis of subchondral area, cyst formation, and osteophyte formation. We all know this medial joint line. It is done in 90 degree flexion in joint. This is KL scale with KL scale. We are doing the grading of knee joint with X-ray. Always notice, you should advise the X-ray of knee joint AP view in standing. AP view in standing. Please note, from tomorrow onwards, definitely we shall write X-ray of knee joint, X-ray of knee, affected knee, only right or left or both knee, AP on standing and lateral. AP on standing. Definitely you should advise AP view on standing. And on standing, we are doing this grading. Doubtful narrowing of joint space and possible osteophytic limping is the grade 1. In this particular situation, no patient come to OPD. It is very rare to see this grade 1 X-ray with complaint of patient. Why? Because in this particular situation, the patient may not come to OPD. The most commonly patient come to OPD with the grade 2 X-ray. Definitely, if we find a patient with medial joint line tenderness and whenever there is morning stiffness and resting pain, definitely after the clinical examination, we shall advise X-ray. We shall advise X-ray from the very first sitting itself. In grade 2, there will be definite osteophytes and possible narrowing of joint space. And please note that the medial compartment will be less than lateral compartment in grade 2. In grade 2, AP view on standing, the medial compartment will be less than lateral compartment when we are doing AP view X-ray in standing. And in grade 3, definitely there will be large osteophyte, multiple osteophyte, definite narrowing of the joint space, and there will be sclerosis. And possible deformity of the bone ends. This is grade 3. I will explain the management protocol with this grading. With this grading, I shall explain the management protocol. And in grade 4, definitely there will be no space. Completely space restriction will be there. Large osteophyte, definitely deformity will be there. And please note that varus deformity is more commonly affected with osteoarthritis and valgus deformity more with rheumatoid arthritis. And to differentiate rheumatoid arthritis from osteoarthritis, rheumatoid arthritis from osteoarthritis. In rheumatoid arthritis, the joint space narrowing will be symmetrical. But in osteoarthritis, joint space reduction will be more on the medial compartment. There will be unsymmetrical joint space reduction in osteoarthritis. And osteophyte formation is seen in osteoarthritis. Osteophyte is seen in osteoarthritis. In rheumatoid arthritis, there will be osteoporosis. With these changes, we can definitely rule out or differentiate osteoarthritis and rheumatoid arthritis. I will explain once more. There is an X-ray. I will show you that. And there will be more chance of varus deformity in the osteoarthritis. And if there is a 30-degree deformity, if there is more than 30-degree deformity, in such conditions, the TKR may not be much effective, total knee replacement. So, if a patient come to you with a grade 4 osteoarthritis, and that patient went to an orthopedician and they advised TKR. And if the patient needs more walking, more weight bearing, in such conditions, our prognosis is not much good. If the patient demands our treatment, with very less walking. In grade 4, we can take up that case, but our prognosis is not much good. Definitely in grade 4 osteoarthritis, it is better to go for total knee replacement. But if the patient denies that particular treatment, then we can take up that case after explaining the prognosis. If the patient needs more walking, more weight bearing, in such conditions, our prognosis is not much good. This X-ray tells the difference between weight bearing X-ray and non-weight bearing X-ray. This is the X-ray of same patient with non-weight bearing AP and weight bearing AP. See the difference. So that definitely we shall advise AP view in standing. And in osteoarthritis, definitely these 5 hallmark signs, that is narrowing of joint space, asymmetrical, subchondral sclerosis, subchondral cyst, osteophyte, and lack of osteoporosis is suggestive of osteoarthritis. And we can do this timed up and go test. This is timed up and go test. We can see the patient should walk a distance of 3 meters. The patient should walk a distance of 3 meters, and it is video documented. The patient should walk from a chair a distance of 3 meters and then return to that particular chair. In the first OPD visit, it takes normally 35 seconds for this particular patient. Normal is 10 seconds, below 10 seconds. After this class, you may check from a sitting chair after walking for a distance of 3 meters and return to that chair. Normal is below 10 seconds. This is actually after 4 weeks management. This is not normal. It took 12 seconds to complete this, but the patient's pain and deformity, swelling, such things are very much reduced. Not deformity, pain and other discomfort are very much reduced. Regarding management of osteoarthritis, the initial Amapajana Shofahata management is needed in the very beginning. Initially, surely there will be morning stiffness and resting pain. And after that, internal Sneha Prayoga is needed. Internal Sneha Prayoga is very important in the management of osteoarthritis. And along with internal Sneha Prayoga, definitely rehabilitation and also nutrition. Nutritional management is also very much important in the management of osteoarthritis. Regarding the protocol, this is very important in the management of osteoarthritis. You shall do the clinical examination and radiological investigation, X-ray investigations. And regarding this protocol, if a patient comes to you with grade 2, grade 1 is very rare. Grade 1 requires only very less management, and surely you shall advise that patient rehabilitation. And if it's a grade 2, Amapajana and Shofahara medicines, mainly Kerala traditional medicines like Pajana Amrda, Amrdotra, such medicines can be used, or Rashna Panchaka can be used. It shall be used for a period of 2 weeks initially. And then we can change to Brahmana Kashaya like Vidaryadi. And along with that, rehabilitation shall be advised. Please note that rehabilitation should be avoided in the very first setting. Why? Because if there is AMA associated or SHOFA associated with pathology, then we advise this particular rehabilitation. It will cause aggravation of pain. So in the very first setting, from the beginning, we shall avoid this particular rehabilitation. And after Amapajana and Shofahara, definitely we can see the difference, the flexion, the gait, walking pattern, everything will change. And in that particular condition, after the initial pain management, the patient itself will tell you there is a reduction in the morning stiffness and resting pain. In that particular condition, we may change to this Brahmana Kashaya and start rehabilitation. And if needed, we can add a small amount of internal Sneha along with this Kashaya. After a 4 weeks management, if it's a grade 2 osteoarthritis, after 4 weeks management along with the rehabilitation, whenever the patient comes to you and the patient explains, there is no morning stiffness and resting pain. It is completely absent. And the patient feels exertional pain. That is the moment you change the medicine. Patient typically feels mechanical pain or Exertional pain. After doing some activities, patient felt pain. One stiffness and resting pain is completely absent. In that phase, we shall change to internal sneha. And internal sneha, most commonly, I am using that Taila internally. We can use Manalpaga itself. There is no need to go for always Medupaga. Some Taila we don't get Medupaga. In such conditions, we are using Manalpaga. And this Taila Manalpaga can be used internally. Or Tikta or Asna Dashamuladigrada internally as per the condition of the patient. You can opt as per your condition. There are a lot of options, but the protocol based on grading, this is important. And the clinical examination and diagnosis, it is the first thing. And then this protocol based on grading, we can give better results within 6 weeks. Within 6 weeks. And if the patient is continuing rehabilitation, there won't be any pain. There won't be progression. And end with Rasayana, we can use this Tila or Amalagi. Such Rasayana can be used. Simple Rasayanas, or we can advise Gandha Thaila for that patient. Such simple Rasayanas can be advised for that particular patient at the end, and rehabilitation should be continued. And regarding grade 3, it requires more Amapajana Shopahara management. And if the patient needs to stand for a while, then we shall advise any brace for that patient. And in the next phase, we can change to Brahmana Kashaya, and rehabilitation shall be started. It shall be started after 3 to 4 weeks. And it may change patient to patient. More commonly, on an average, I am taking this particular time period. But if you don't get result in this time period, then either we check our protocol, or we shall refer that particular patient. If the patient has above 100 weight, the patient needs to stand more time. The patient is not getting result after 4 weeks, then we shall think either we change our protocol, or we shall refer that particular patient. And in the next phase, internal sneha, and in that particular phase, we shall avoid orthosis. The orthosis should be avoided, knee brace should be avoided. Regular use of knee brace is not much good. But if the patient needs to climb up a stair, then at that particular moment, ask the patient to wear the orthosis and avoid orthosis in all other conditions. And then with Rasayana, it shall continue for 3 to 4 months. And regarding grade 4, I already explained that the definitive treatment is surgical management. It is better to advise that particular patient. Why? Because if the patient feels fear for TKR, and they are coming for a second opinion, and we ask the patient how much demand that patient needs regarding weight bearing. If the patient need to walk more, patient need to climb up to get into their house, if the patient lives in such an area, then definitely that particular patient should be referred for TKR. It is better to go for TKR. Not always it should be done in private hospitals. In government hospitals like General Hospital, such needy patients, they are doing TKR with very minimum amount. Only the prosthesis amount is taken from that particular patient. Such centers are also there, but it is very less. If sometimes we refer a patient to a medical college for TKR, it will be denied. That patient won't get result. But in General Hospital, Ernakulam, actually there are 3 orthopedic surgeons. They are helping patients by doing this ACL repair, TKR with very minimum amount. I am referring such patients for them. For this needy patients to General Hospital Ernakulam, they are doing so. In such patients, such needy patients, we can refer them to a nearby government hospital, but make sure they are doing such things. In private hospital, it costs more, but if the patient is able to do it, and if it's grade 4, if the patient has severe pain, not responding to conservative management, then we don't continue treatment in such patients because it's not ethical. And if the patient only have less demand, and it's grade 4, then you can follow this particular management protocol. And Snehavana is must in that particular patient. Matravasti is must in that particular patient. Definitely, we shall advise rehabilitation. Rehabilitation is very important. If a patient come to you and wearing this particular orthosis, ask the patient to avoid it, because actually it itself causes wasting of muscles, and it causes more osteoarthritis in very less time. because the aggravation of symptoms will be very much in this particular patient if they are continuing use. So advise the patient to avoid such things, and definitely you shall advise this rehabilitation. And this is regarding difference in osteoarthritis and rheumatoid arthritis. Here in osteoarthritis, there will be asymmetrical space reduction, osteophyte formation, and there is no osteoporosis. Here there is symmetrical space reduction, osteoporosis, and no osteophyte formation. And this is chondromalacia patella. Chondromalacia patella is common in females, more common in females. It may occur in males also. And in this chondromalacia patella, it may occur in small young-aged people when they are continuing sports, or it may happen around 30 age group. This is the clinical examination test. Fix the patella superiorly with the first and second web space, and ask the patient to contract the quadriceps. Ask the patient to extend the knee joint. Whenever the patient extends the knee joint or tight the quadriceps muscle or contracts quadriceps muscle, the patella will move proximally, and we are fixing the patella to avoid that particular movement which causes pain in chondromalacia patella. This is another clinical examination test. You shall only do one clinical examination test. This is the Skyline View. Here we can see the chondromalacia patella. This is the normal Skyline View. And this is an Insal-Salvati index. Why? Because in patella alta, you may see the report patella alta. In Insal-Salvati index, this is 1/2. 1/2 means the distance from the inferior pole of patella to the tibial tuberosity, and the lateral complete distance of patella. This is 1/2. And whenever there is patella alta, the patella is placed superiorly. The Insal-Salvati index will be above 1.4. And in that particular patients, there is more chance of chondromalacia patella. In young-aged people itself, this particular test will be positive, or Clark's test will be positive. Patient feels pain over the retropatellar area. Such patients, and also 40 plus females, shall avoid these lunges, deep squats, and leg extension machine to avoid chondromalacia patella. Thus, chondromalacia patella patients who are doing this exercise will aggravate the particular condition. In chondromalacia patella, these exercises shall be advised. The diagnosis is important. The management protocol, we can follow the same as that of osteoarthritis. And this is a pain at tibial tuberosity commonly seen in 15 age group. We can diagnose it with as the patient to extend the knee against our resistance. As the patient to do extension of knee against our resistance. And this is particularly clinical examination test. As the patient to extend the knee against our resistance. If the patient feels pain over the tibial tubercle, then it's suggestive of Osgood-Schlatter. It is more common in 15 age group. In 12 age group, there is a disease called Johansson-Larsen. It is not much common, rare. In that particular condition, inferior pole of patella is affected. That age group is 12. In 15 age group, the tibial tuberosity is affected. And in between 15 to 30, more commonly patellar tendon is affected. The clinical examination test for all three is same. As the patient to extend the knee against our resistance. This is seen in Johansson-Larsen. Inferior pole of patella is affected. In Osgood-Schlatter, at the age group of 15, tibial tuberosity is affected. If the patient needs to continue sports activities, we can advise this particular strap. This is a patellar strap. We can advise this in the initial phase, and these exercises should be advised. The exercise is important in Osgood-Schlatters. Regarding pain over lateral femoral condyle, this is iliotibial band syndrome. 2 centimeter proximal to lateral joint line is the pain. There is a small difference in all area. The attachment or insertion point is the most common site of pain, but here this is not the insertion point, but the pain is over the lateral femoral condyle. There is more friction. The lateral iliotibial band causes more friction over this particular lateral femoral condyle on flexion and extension. Walk on slanting surfaces, continuous running, continuous cycling, hiking, such conditions may cause this particular pain. It is common in above 50 age group also. This is not a sports injury itself. It may cause above 50 age group males and females who walk on these standing surfaces with weight, who are doing rubber tapping, such things. They are weight bearing, such things, and also they are walking through these landing surfaces. This may cause pain over the iliotibial band. This is the most common site of pain, lateral femoral condyle, 2 centimeter proximal to the lateral joint line. The clinical examination test is ask the patient to stand on the affected leg and then flexion of knee joint. A 30-degree flexion itself causes pain over the lateral femoral condyle. We did this particular clinical examination in the meniscal tear, Thessalis test. In Thessalis test, we are doing rotation of femur on tibia, which is suggestive of meniscal tear. Here in Rennes test, we are only doing the flexion up to 30 degree. In this particular condition also, if the patient needs to continue sports activities, we can advise this strap. The position of strap is different. In OSG, the position of strap is here. In ITB, the position of strap is here. And in patients with Pitta Koba, we can go for this modified Syringa. If the patient has more Pitta Koba, in such cases, we can go for modified Syringa using number 12 blade attached in a BP handle. We are giving small pricks, and then we can do modified Syringa at the tender points. If there is not much Pitta Koba, then our protocol is Navasandhi Sira Prapte Sneha Daha Ubanahanam. First, we shall do Ubanaha for 3 days with internal Amabhajana Shofahara medicine. For that, we can either use this Amrudotara Bhajana Amrita Punarnavadi, or we can use Dashamulam plus Dasna Panchakam. And then with a blowtorch, we are heating this Shalaga, and then we are doing Agni Karma. In injury management, we can use Liguja Taila. I forgot to tell that in injury management, we can use Liguja Taila, which is explained in Chikilsa Manjari. So Liguja Taila is available. That can be used in the initial phase along with Morivana. The indication itself is Ruja and Rudra Sruti, which is suggestive of internal injury. With the Shalaga, Snavasandhi Sirapapte, Snehadaha Manahana can be done in ITB, iliotibial band syndrome. Please note that Liguja Taila is advised in injury, not here. Here we can use this particular management protocol if needed, not in all cases. Not in all cases. We can use this rehabilitation for iliotibial band syndrome. Please note that regarding iliotibial band syndrome, the patient most commonly may be a sports person, so that definitely I advise the patient to do proper hydration before sports activities. Second thing, proper warm up and cool down, then nutritional supplement, and finally core muscle strengthening of hip abductors and adductors are also very essential to avoid iliotibial band syndrome, recurrence of iliotibial band syndrome. Prepatellar bursitis and infrapatellar bursitis. Regarding bursitis, initial rest and then lepana with either Nagaradi or Ellu Nishadi can be used with internal Shofahara medicines. In a very less period, it is subsided. And regarding chronic treatment, I already explained the management protocol of osteoarthritis based on the grading. We can use the same for chondromalacia patella. Regarding this ITB, Osgood-Schroeder's, initially we can use this Amashofara if it's due to this pathological repeated strain injuries. And as per condition, we can use either Ubanaha or Labana. For that, we can use this Ellu Nishadi or Nagaradi. And if needed, modified Syringa or Agni Karma shall be advisable, not needed in all cases. But for a quick relief, if the patient needs to continue the sports activities within 3 days or 5 days, it is better to go for this, our Anushastra procedures. Jaluga Avajarana is also effective in this particular condition. To avoid recurrence, I already explained that rehabilitation and internal Sneha Prayoga. Internal Sneha Prayoga, either Tikta Rasa, Ghrutam, or internal Sneha Taila, like the Anudara Taila, along with Gandha Taila can be used. Proper warm up and cool down, and proper hydration with solute replacement to avoid recurrence. And nutritional support, yoga, pranayama, and mental assurance is also important. We also see this rehabilitation. This is against resistance exercise using a band. These two are for quadriceps strengthening. This is in prone position, and this is on standing position. Please go through the rehabilitation. Rehabilitation is equally important as internal Sneha to avoid recurrence. Hope you remember the Clark's test. Clark's test is fix the patella superiorly and ask the patient to contract the quadriceps to rule out chondromalacia patella. Fix the patella with the first bed space and then ask the patient to contract the quadriceps, which resists the proximal movement of patella, which is suggestive of chondromalacia patella. Chondromalacia patella is very common in sports persons with patella alta. With patella alta, it is very common. So many patients may come, either basketball player or those who are doing sprinting, such patients may come. Definitely, we get result with our management protocol. The patient is able to do all the sports activities. And this active SLR, I already explained. The active SLR we are doing to check whether the extensor apparatus of knee joint is patent. Extensor apparatus of knee includes quadriceps tendon, quadriceps muscle, quadriceps tendon, patella, and patellar tendon. And Rennie's test. Rennie's test is for iliotibial band syndrome. Rennie's test is ask the patient to stand on the affected leg. Hope you remember, always do first clinical examination in the normal limb and then on the affected limb, and always compare the muscle wasting with the normal knee joint and the range of motion also with the normal knee joint. In Rennie's, ask the patient to stand on the affected leg and flex the knee up to 30 degrees. Surely there will be tenderness on the, pain over the lateral femoral condyle, which is suggestive of iliotibial band syndrome. If the iliotibial band syndrome is not managed properly initially, the pain may proximally radiate up to the hip. If it is not managed and the patient continue with the normal routine activities, either sports or the daily routine activities, the pain proximally radiates. And patellar tendinitis test I already explained regarding Osgood-Schlatter patellar tendon test. And for Johansson-Larsen syndrome, ask the patient to extend the knee against our resistance. That is the clinical examination test. And this Thessalis test is for meniscal tear. In Thessalis test, stand on the affected leg with weight bearing and then flex up to 30 degrees and then rotate the femur on tibia. It should be done 3 times and patient hands should be rest on the examiner's hand. Tuck timed up and go test. Normal is below 10 seconds. Patient walks from a sitting chair up to a distance of 3 meters and return to that particular chair. Normally it takes below 10 seconds. But in osteoarthritis patients, if it's a grade 3, it may take up to 69 or 70 seconds. And if we can reduce it to 15 or 20 seconds, not up to 10 seconds. If it's a grade 3, it may not become up to below 10. But this difference from 69 to 15 is very significant regarding the quality of life of that particular patient, and we can do that with our conservative management. But please remember, if there is no prognosis with a grade 4 osteoarthritis with deformity, definitely we shall refer that patient. We don't take up that case. That is the ethical practice. To do ethical practice, we should be scientific. And Lachman's test is more confirmatory than Royer's in ACL, anterior cruciate ligament tear. I show the video of ACL Lachman's test. In Lachman's test, in 20-degree flexion, fix the femur and pull the tibia anteriorly. When there is ACL complete tear, then there will be translation of tibia up to 1 centimeter, up to 10 mm. And the last one is abduction test, which is confirmatory for the medial collateral ligament tear. In abduction test, one hand is fixed on the knee lateral aspect, and then abduction of the knee is done with holding one foot, and there will be excruciating pain when there is pain. When there is complete tear, the joint will open up. This applied anatomy is very important, and clinical examination equally helps us in the diagnosis. The sudden giving way happen in hyperuricemia, osteoarthritis, ACL, and meniscal tear. And meniscal myth is healing only on outer layer. It is an avascular structure. And our strength of our management is cost-effective methods. Weakness is surgery. And our opportunity is bandaging and rehabilitation. Bandaging, rehabilitation, and anesthesia is our opportunity, and our threat is coax. Coming to conclusion, please remember the management protocol of osteoarthritis we explained. Regarding meniscal tear, ACL, and collateral ligament tear, the injury management protocol is very significant in all these 3 conditions. And regarding chondromalacia patella and ITBS, I already explained the management protocol. History of injury and pathology, both are important. How the injury occurred, it definitely gives the provisional diagnosis. And also in pathological condition also, what the patient was doing. If the patient is walking in a slanting surface with weight, then we can come to the provisional diagnosis of ITB. And the specific diagnosis, whenever the patient tells us the patient is not able to climb down, and the patient stand up from a sitting position, whenever the patient stands after a continuous sitting, that pain, the patient is not able to climb down, it is suggestive, this particular condition is suggestive of chondromalacia patella. Specific diagnosis will be done with clinical examination and relevant investigations. You shall use relevant investigations if needed, and is earlier tradition with Patya and Anushastra with proper rehabilitation and true mental assurance after assessing the prognosis is very important. The value of experience is not in seeing much, but in seeing wisely, said by the great clinician William Osler. Thank you. Thank you very much. Thank you very much for the opportunity. I am thanking once again the organizers. Thank you very much.
Thank you, Dr. Diku. It was a wonderful, very informative class. If any question is there, you can ask or you can message in the chat box. Liguchadailam in which company?
Vaidiratnam.
Vaidiratnam, okay.
Namaskar, sir. My question is that if there is joint effusion is also accompanied along with injury, like in tear, so can we manage in joint effusion also?
The joint effusion will reduce along with the management of injury. Surely there will be joint effusion. If it's a ligamentous tear, then there will be effusion associated with blood. But if there is meniscal tear, then there won't be blood. It may be more effusion associated with the serosanguinous effusion. It may differ, but the effusion typically reduces with our management. And also, I must tell one differential diagnosis, that is septic arthritis. Regarding septic arthritis, definitely we are doing one Koch's criteria. It can be done within 2 hours itself. That means if the patient come to, mainly the patient is not able to bear weight and unable to do any movements associated with knee joint, but there won't be any history of injury. In such conditions, definitely we shall check ESR and CRP and check whether there is fever. But fever won't be seen in the very beginning, but ESR will be raised above 100 and CRP will be about 20. And that condition, fever, CRP, ESR raised, and the next one is the patient is not able to bear weight or unable to do any activities related to knee joint. That condition is septic arthritis, and definitely we shall refer that patient for synovectomy. Immediate reference is needed. But if we wait for 1 day, then that joint will be distracted. So that in that particular condition, the redness and fever, please don't wait for that. It may happen after hours, 6 hours or 12 hours. So if these 4 criteria, that is Koch's criteria, 4 is positive, means it is 99% suggestive of septic arthritis. And if Koch's criteria is negative, then there is 0.2% chance of septic arthritis. So that if there is a provisional diagnosis or if you suspect this particularly septic arthritis, that patient should be referred immediately to an orthopedic surgeon for synovectomy to manage that particular condition with antibiotic cover. But all other effusion, all other swelling will be subsided along with our management. It can be managed.
Okay, thank you.
Hello. Hello. What is the management of synovial fluid increase in the both knee?
If there is synovitis, then internal medicine can be advised. But if there is increase in synovial fluid, then tapping should be done. Tapping.
Sometimes we're tapping the fluid. Then
Yes.
again, synovial fluid increase in the both knee. Then what we can do?
Then tapping should be done. Tapping of fluid should be done.
After tapping again and again tapping.
No. It should be done. It should be done only once. Only once.
We do again 2 times or 3 times. There is a lot of synovial fluid. Then what we can do it?
Actually, I don't know.
Any other question?
Hello, sir. Which medicine we can do in synovial fluid? Hello.
Synovitis, internally, we can use Amrudashta Punranavasa Vettumaran can be used if there is synovitis. We can use internally.
Okay. Any pathological finding? Okay, thank you, sir.
One question. Management of pad injury. Can you explain? Pad injury.
If the patient come to us in the initial setting, the same injury management protocol can be done. Injury management protocol can be done from the very first initially patient visits us. If the patient come to us after a while, then rehabilitation itself can be advisable. But if it's a fresh injury, the injury management protocol can be advisable, which we explained.
Your experience with the Laksha Gugulu.
Laksha Gugulu and Abha Gugulu are very effective mainly in the injury management. In the injury management, mainly I am using more Abha Gugulu than Laksha Gugulu. Both are advised in Chakradatta Patnadhikara. Just below to Laksha Gugulu, Abha Gugulu is advised. And I am using more Abha Gugulu than Laksha Gugulu, but Laksha Gugulu is also equally effective to Abha Gugulu, and in the initial management of injury setting, we can use both of this. And in the second phase, it is better to use Gandhadaila internally.
You can ask any question. Please message in chat box or directly.
Sir, my question is other than knee joint related to AVN. Can I ask about it?
Sure, why not?
Sir, in grade 1 and grade 2 AVN, how far we can manage means to avoid surgery?
Regarding AVN, our aim is to delay the surgery. Why? Because surely there will be revision surgery needed if it's done in the early phase. The prosthesis longevity is more commonly 10 to 15 years or maximum up to 20 years. Maximum is 20 years. So surely there will be revision surgery will be needed. So that to delay the surgery, we can advise hip spica bandage as a support to the patient, swastika bandha, and we can manage by internally giving in the vasti as tikta shira krata vasti. Tikta shira krata vasti can be used. Internally, this mamsarasa sneha prayoga snehavana can be done after the initial amabhajana shofahara management or to maintain after the maintenance of acne, we can give internally tikta rasa grada internally and also tikta shira grada vasti can be done. With this, we can maximum delay the surgery. Also, we can give proper rehabilitation, mainly isometric hip rehabilitation to strengthening the muscles. Matravasti can be continued for a prolonged period. We can advise the patient to do matravasti in the home itself for a prolonged period. It also helps a lot. If we manage a 20 case, we can delay surgery in this 20 case if it's grade 1, grade 2. But if it's grade 4, then our prognosis is not good. It should be referred for immediate surgery. Some cases, 1 or 2 cases, it was found to be better in X-ray also. In X-ray also, 1 or 2 cases, it was found to be X-ray, both clinically and radiologically. But all other 18 cases, if it come to us in grade 1 or grade 2 stage, we can delay surgery for a prolonged period.
Did you give Gugulu Tiktaga Gridam in these cases?
Yes, Gugulu Tiktaga Grada can be used, Tiktaga Grada can be used, and also Mahatikta Grada can be used.
ONE or any other ligament injury cases after Amabhajana?
Yes, surely this Tikta Grada and Tikta Grada is very effective both in injury and pathological conditions at the time of internal Sneha Prayoga. Also, we can use this Dashna Dashmuladi Gradam and also we can use this Danudra Taila along with Gandha Taila.
Which is more effective compared to Danudra Taila?
It may differ from patient to patient.
How can we select the Thailam or Gradam according to Prakriti or according to?
No. It mainly depends on specifically injury or pathology. In injury, it is better to use internally the Anudra Thaila along with this Gandha Thaila. It will be more good. In pathological condition, mainly degeneration, it is better to use this Tikta Garda. And the difference is that we can only give Thaila in less quantity. That means like Grada, the patient won't take that much Thaila internally. Maximum 10 to 15 ml Thaila can be used internally. And regarding internal Sneha Prayoga, it is better to use more quantity in less period than less quantity in more period. More effective method is more quantity in less period is more effective than less quantity for a more period.
Sir, maximum how much quantity of Grada we can take?
Grada can be internally given as per Agni Bala for if we are doing Snehavana in grade 3 or grade 4 osteoarthritis, we can give as Arohana Matra up to that patient's capacity. But for daily as Shamana internally, we can use a 50 ml or 20 ml. But Thaila maximum 15 ml is the maximum limit. Grada can be up to 20 ml. We can use as Shamana Snehavana.
Dhanvantara Nutanavarti is also effective, no? We can give with
Dhanvantara Nutanavarti can be given, but it only requires very small quantity. I am more commonly using this Dhanvantara Thaila Manal Paga internally, up to 10 ml or 15 ml as per patient. For some patients, it may only up to 5 ml can be given. In chat box, there is a question: Leba yogas are used in acute injury or only Muruvana is used for bandaging? In acute injury, there is no need of usage of Leba, as per my knowledge and as per my gurus. That means Chandrakumar sir, Matthew sir, and Suresh sir. As per them, and also as per my knowledge, it is better to avoid Leba in the initial phase. Actually, to reduce the swelling itself, bandaging is advised. The role of bandage is to reduce swelling, and this Muruvana is used to reduce the Pitta Ratta Koba in the initial phase. So there is no need of Leba in the initial phase. Initially, we are using bandaging. Bandaging itself is the protocol. No need of Leba in the acute phase. And after bandaging, at the time of rehabilitation, if there is swelling associated, there is stiffness associated, then Lebana or Ubanaha should be done. If there is muscle wasting, then Brahmana Ubanaha can be done. And in osteoarthritis also, in the initial phase, we should not use any external application, including Leba and Thaila. In the initial phase, it is better to go internal medication itself. No need of external application. Any external application, if we are doing a research work in our patients itself, we can find that the external application delays the result. With internal medicine, initially given internal medicine itself gives more result than any other external application, including Leba and Thaila. So it should be avoided. And after our management, if some patients are regularly using Muruvana externally, then it may cause aggravation of symptoms. In osteoarthritis, I am telling, in osteoarthritis, after the management, if the patient is regularly using Muruvana, then it aggravates the condition. So that external application of Thaila should be avoided in such conditions of degeneration. And also in rehabilitation phase also, it is better to avoid Muruvana in rehabilitation phase to increase the range of motion. In such conditions, it is better to do Ashavana and Pindadaila Dhara. Ashavana more, Pindadaila less. Such Dhara should be more effective. Thank you.
Hope no further questions, so we can wind up the session. Okay, Dr. GQ, thank you for your very nice presentation. Thank you. Thank you, everyone.
कहाँ है रे? अरे, ये सुनो ना, छोड़ जाओ, दूध ले आता हूँ। आओ जल्दी आओ। हाँ ना, हाँ चलो।